Good morning. Does everybody love yesterday's content? Yes. Wow. Congratulations to the T1D exchange, but most importantly, all of you, because you're the ones who do the work. I'm Anastasia Albanese O'Neill. I'm with JDRF, but I spent 14 years at the University of Florida engaged in this work, and I'm delighted to be with you today. This session, just to make sure you're in the right place, is called Planning, Engagement, and Shared Decision-Making. And I think this is where the rubber hits the road because we do all of our work in partnership with families. And I'm not going to stand in the way of what we're all here to learn about. So I'm going to introduce our first speaker. Her name is Dr. Rachel Fenske, and she's going to be talking about implementing patient-reported intake forms to integrate clinic efficiency with patient-centered care. So come on up. Let's get underway.
Thanks. Well, I'm happy to be here and talk about the work from our team. And we'll just get started. Oh, perfect. So just briefly kind of set the stage here for what we're working with in Wisconsin. We have a pediatric children's hospital that's located downtown, and then we have 2 outpatient clinics. And the work that we'll be talking about today is taking place at one of our outpatient clinics and really trying to maximize our time, our face-to-face time with patients, while also really centering the visit around, what they want to talk about and what they're focused on for the day. So in order to understand our problem, you got to understand our workflow a little bit. So when a patient comes for an outpatient visit, they are always going to get roomed by one of our MAs, and they'll also always see a nurse and a provider. Every 6 months to a year, they're going to see one of us dietitians. And I just wanted to highlight here, there is a lot of redundancy, even though we try to reduce it, in kind of what questions are asked between providers. And that's something our patients have brought up to us. And we also, our nurses spend a lot of time in that visit talking through what we call, I've termed here, clinical diabetes information, or some metrics that we like to collect and the hospital likes to see for US News and World Report. And it takes a lot of face-to-face time for the nurses. Again, just for reference, our average visit length is 80 to 90 minutes. And while, ideally, if we could reduce that time, that would be great, but we really just want to make that time the most efficient possible. No, you're good. So I'm going to keep just rolling. So our thought process here was if we could collect that pertinent information, that clinical diabetes information ahead of the visit, rather than have our nurses spend that face-to-face time going through that, we could make the visits more efficient and spend more of that time focused on our family's priorities and kind of what's most important for them for the day. Oh, I can't change. It's okay. Yes. It's all good. Amazing. Yeah, you're good. So that information, that clinical diabetes information, we turned into what we've termed a patient-reported intake form, or a PRIF. And really, when our nurses collect that information, they enter it into the electronic medical record into a flow sheet. And so we essentially turn that flow sheet into this form. And that's really the meat of what you're seeing here. We also added kind of the blue box on the left. We added what our patients and families wanted to be the priority. So a couple open-ended questions. Chat doesn't bother me as long as it doesn't bother you. And then here, I'm not going to talk about it today, but we did also add a couple questions, our food security screen and our transportation security screen here at the end. So now after we implemented the use of this form, our workflow looks a little bit different. So when our patients arrive in clinic and are checked in, they're given this form, which then they complete while they're waiting in reception to be roomed. Our MAs then bring the families back. They collect that completed form, but they also do a point of care hemoglobin A1C. They're downloading any tech, and then they bring all of that information and hand it off to our nurses. And that way our nurses can spend the time, quickly entering that information before they go in the room. And that way when they're entering the room, they can focus the visit on either things that have come up on the form that maybe are educational needs, or really whatever the family would like to talk about. Or they don't have to necessarily spend 15, 20 minutes if it's not needed in the room, and shorten the visit for the family. And what we found was that in our kind of pilot here of 42 clinic visits, that this workflow was acceptable to families. And the form was usually filled out pretty completely. 82% we felt was pretty good. one of the downsides that we found in this pilot was that those first 2 questions, which we were really excited about, patients and families are going to tell us what they want to talk about. They just left them blank. So that was one area where we were going to maybe think about how we could improve this form. We also checked in with our nurses. This really impacted their workflow, and we didn't want to impact their engagement at work. But our nurses seemed to accept and like it for the most part. They felt like the conversations they were having with families were more meaningful. They could kind of gauge their diabetes engagement before they went in the room based on how that form was filled out. They had more flexibility with that face-to-face time. Of course, a couple downsides, a little bit less nonverbal feedback when you're not asking those questions to the family. And also, unsurprisingly, some of it wasn't filled out accurately. We had some medication refill questions that almost always are filled out wrong. And so again, an area that we can kind of think about improving. So we have now rolled this out to our second outpatient location, knowing that it was both acceptable and feasible. And we're making some improvements with those first open-ended questions. We're going to try to integrate the My Diabetes Journey prompts to see if that can kind of help guide families in choosing some priorities for the visit. Again, just continuing to work on reducing redundancy with those medication questions we're going to remove. And of course, we want to get more feedback from our patients and families. We kind of anecdotally grabbed a couple comments, but now we've rolled out a survey and we started getting some responses, which has been really helpful, and we're excited to integrate their feedback. And now thinking again, I know I heard this a couple times yesterday about reducing survey burnout, is they're getting a lot of forms. They have this form, they get a PHQ-9, they get a screen for disordered eating. So we have a lot of paperwork going around. And so we're thinking about better ways to just reduce how many forms are getting filled out at each visit. Ideally, these are a couple pie in the sky goals for our organization. Electronic form completion would be great on an iPad. Unfortunately, our organization is pretty averse to using those. So that's something that we're continuing to work on, but has been a challenge. And same with the Patient Advisory Council. Dr. Liz Mann, who's unfortunately not able to be here today, has done a lot of work to try to get this started. And again, a lot of roadblocks and barriers, but we really want to integrate our family's feedback. So it's something we're thinking about. So gotta shout out to the team, always rolling with the punches as we make these changes to their workflow and our patients and families, and really grateful to the T1D Exchange and the Helmsley Charitable Trust for their support. So with that, I'll take any questions.
Thank you. That was great. Lauren Golden from the adult world here. We have I think a similar concept. We created a questionnaire that's sort of quarterly that goes out to the patients, and it was built based on all of the goals and things that we're supposed to be trying to collect for here. 2 questions for you on implementation. That goes directly to the patients quarterly in Epic, which is what we're using. Yeah. And then, right. And then I think we got a little stuck with the pandemic. It maybe not as a team really conveying to them how important it was to fill it out, but which I think we can work on. The actual practice flow, though, the data comes in. If anyone on the team besides me looks at it, it's not clear, but I do look at it. Then we have to go in and verify it and file it and go to another page, which is a flow sheet, which I have to say nobody's going to do. And so I kind of demoed it as a pilot on myself. And so it's patient reported. I understand, the need to verify. But I'm curious if anyone has any better implementation, because then I think we could really get the patients to fill it out. And it does include open-ended questions and also when was your last eye visit. And then MCIT created some text to flow that into our notes. I just find personally going back and forth to flow sheets and here and there and out of the chart to make the visits longer. We have great nurses, but they're not at our disposal for this. It has to be at the provider level on the adult side, I think, for most of us. And it's not clear to me how to make that less tedious and burdensome for us, so it's not happening. So I don't know if anyone has thoughts about that. Yeah. Do you want to? Yeah. Sure.
So I'm Joy from Seattle Children's. We actually have successfully integrated the patient-centered questionnaire into Epic. So they fill it out on an iPad. It goes directly into our flow sheet. We are able to do that. And I'd be happy to connect you with our analysts who can do that, because it does reduce that piece of the nurse having to then verify that data. And it goes directly into a flow sheet. The provider can pull it up, take a look at it, and then address those questions in that. So yeah. So that is... Yeah, it's in there. Right.
But we're not using it at the clinic visits because people find that cumbersome. I think that's our problem to some degree.
Yeah, I think it's a matter of teaching. And we also made that flow sheet a hard stop for our providers. So our providers have to look at the flow sheet.
You can train us. Thank you.
Hi, not related really to the intake form, but what eating disordered screen do you do and how do your patients feel about it?
No.
That's okay. So we use, it's a modified SDE. So we use the SDE screen first, which is 4 questions, I believe. And we're asking it verbally since our dietitians do go in, we were asking it, but it's validated in a written form. So we end up changing it to a written form. There were a couple questions on there that our patients were not really keen on. So we did modify it. I'm happy to send you what our modified screen is. Yeah. It's not validated, but it's works. Yeah. Any other questions? Great. Thank you for your feedback.
Thanks so much. Wonderful. All right. So we're going to move on to our second speaker. I think. Let's see if I can. It should come up. Excellent. So we have Nicole Rioles from the T1D Exchange. She's going to speak with us about engaging people with diabetes and quality improvement, clinical projects, insights from the T1D Exchange Quality Improvement Collaborative. Nicole.
Thank you, Anastasia. And could I add, are you our timekeeper? I just want to make sure that we're driven. Okay, thank you. I will be speedy, but I just want to make sure I know who's doing that. So I think almost everybody in this room has done an orientation with T1D Exchange. And you may remember we showed this slide many, many times of our triangle of like what our foundational goals are to, do QI improvement processes, look at outcomes data together, and address that using, policy work. And in the center of that triangle are engaging with people with diabetes. So we say it's the cornerstone of what we're doing is really, really important. But we haven't done a great job of teaching all clinics how to engage with people with diabetes. So we've done a survey of how many clinics are working directly with people with diabetes for feedback, and the numbers were really small. So I'm going to share quickly data on those results and what we've learned from the centers that are engaging with patients for feedback, and how we can help to support you to have more patient advisors working with you in your clinics. So we did a survey in 2022, and we learned that we had a really low number of patients engaging. And we know that, bringing patients in really helps you all to improve your processes. You understand what patients and families need. You can get real world perspective from people. So this has always been our goal. Our numbers have increased over the last 2 years, but not in proportion to the number of clinics that have joined us. So we wanted to really understand where the success stories were and how we can share them across to other clinics. Last year we surveyed and we learned that 11 clinics had active participation. So that would be, I think, 11 out of 52 clinics. So very low ratio there. We asked those 11 to answer some survey questions. We got responses from 8 of those clinics. So that was our deep learning. We asked more, we did interviews with them. We asked about their engagement. So 73% said that, they had at least an advisor engage with them on their team. Half had advisory panels. Half had people with diabetes joined in QI processing teams, and they all, had meetings of some sort. And this is a combination of Zoom, in person, sometimes team-based meetings. Interestingly, 2 that had really strong advisor roles are supported by policies at the hospital. And I'll call them out. So Seattle and Stanford. And I know it's not ideal, it's not perfect, but those were the 2 examples that we heard. And we'd love, maybe there are people we haven't spoken to yet who have better kind of policies in place, but it does help that there are either stipends or payments that brings a higher rate of being able to compensate. So giving some sort of financial stipend helps you all to diversify the patient group. We have seen that when it's volunteer-based, the patients who can have the privilege of volunteering their free time are largely white, educated, and more affluent. And that can skew perspectives and representation. So we want to try to address that. So clinics with strong engagement really made them true team partners. So a lot of people got email addresses, so they would be, get team messages. Sometimes they go to weekly or monthly or quarterly meetings and have a clearly defined role, so they understood what they were being asked to do, and they could contribute as a member of the team. So I'm doing this really quickly. I'm going to have kind of a random part 2 that I think may be more fun for the group. So we think there's more opportunities to engage and co-design and co-produce with people with diabetes. I mean, really asking how they want to contribute and not, telling them what your model is, maybe a way to result in more engagement, and having clearly defined roles, setting expectations, and empowering them to participate can also help, and with better policies, it can help them to do that. So we can share this as a link later, but we have made a guide. So this is on the portal, and it's like a 7-page guide. We've put it together over the last 6 months for the advisory committee to show how you can engage more with people with diabetes on your teams. And then we asked our advisory committee, what would be your idealized clinical appointment? And this is really my message that, we talk about personalized care, but what does that really mean? And I don't think there's one ideal. I mean, I'm a person with diabetes. Sometimes I'm sitting waiting for a 10 a.m. appointment, and there's just a queue of the same people who have the appointment at the same time. So staggering things to meet people's needs of what they want to do may be a win-win for both sides. So learning how people want to use their time and how they want to even do things like labs can be helpful. So this is just last month, so it's very recent data. We got 28 responses. I think we have more than double that now, so we can kind of update and share more data in the future. So approximately 61% were people with diabetes, and then 39% were parents who responded, and that kind of mimics where they're getting care. They talked about how they want things discussed and planned. We did give them some prompts so that they could kind of choose A, B, and C, but almost 30%, 29% said that using an intake form is helpful, and most, want to talk to their clinician during the visit and ask about that. So this is, and I apologize that I have a title that you can't see now, but this is asking how people want to do labs. And so, some of you have labs embedded in your clinic, some of you do point of care testing. And what we saw for results was really that most people want to, do it either the same day in the clinic or point of care, especially for A1C, is a high priority. And most people did not want to do it after the visit or at a separate time. And then ranking kind of priorities, how people want to use their time. They prioritize, you put this in order. They want you to help with what they need most, talk about what's been going well with diabetes management, what's been challenging, and then significant lifestyle changes were the key things. And then we asked if you were given prompts, what would be helpful. So they prioritized, allowing them to share their own list, to kind of come with an agenda of how time is used in the clinic. And then others, so 18% said giving them a list of topics that they could kind of rank in order of priority. So they prioritized device use as a discussion point, opportunities for change, for new therapies, and then kind of equally spread are things like goal setting, mental health, lifestyle issues, diet, nutrition, exercise, life transitions. And what got less, kind of value was diabetes distress, insurance coverage, DME, which I thought would be a higher percentage, but who knows? Maybe it's the audience of people responding, and then hypoglycemia, hyperglycemia, or hypo. So here are some quotes from respondents. We gave some free text so that they could tell us how they felt. I think this is really essential. They want to be seen as a person and listened to, and we are trying to get away from using the language of patient. Remember, these are people with lives. So that's why we are changing our name to the advisory committee and removing patient altogether. I wish that providers would ask us at each visit if we think the suggestions that they had made work for us, or if we agree with their assessments. I would like to see my doctor ask more style and personal needs. I think it's important for my doctor and where I am in my life and my diabetes management and how it may look for somebody younger or older or a million of other different contexts. They want to have authentic conversations and not have their backs facing. And we know that, when you're in front of the Epic screen, that's sometimes really hard to do. But having a one-on-one conversation where you're making eye contact is always really nice. And we know that we have, the hospital I worked with, patients who did not keep appointments, they were derogatory, names for not kept appointments. But at the same, the reverse of that is, patients also, value their time and they don't want to be canceled with no explanation. So it kind of goes both ways of respecting time of people coming to clinic visit. And the last is, so many doctors waste time to go over things the patient doesn't need. Let the patient drive the conversation so they can highlight their concerns. So that's it. So thank you. And let me know if you had any questions for that.
Any questions from the group? Yes. I'm gonna do a better job with the mic this time.
Thanks for a great talk. I've reached out to you before with questions, how to engage patients. So I appreciate this. I thought the last talk was really great too. And I thought I remembered on the questionnaire, it asked what the patient might want to discuss at a visit and it was left blank. And in your slides, it talks about how patients want to prioritize for themselves what to discuss. So it leaves me questioning, which way is it?
Often do fill that out. So I was actually curious if that was a pediatric not filling it out or no, I don't know. The adults often.
Save the questions at the end of the questionnaire. So they fill out what you're fill out what is, because sometimes it's hard to know, what are your questions when you don't even know what, what are the standard questions that are going to be in there. So then it's you get to the bottom and you're like, oh, now I do have a question. So maybe it's just the timing of it. So they're primed.
As I walk the mic, there was some research on fathers a number of years ago, and they indicated that they didn't want to look like they didn't have the answer in front of the clinician. And so it was a sense of not being exposed as not having the answer and protecting their child. And so maybe that's one of the variables in pediatrics. I'm going to bring it back here to the.
Hi, thank you. So the survey itself, I think is great to have. I'm in adult care and I often see the survey up front and there are 4 or 5 items clicked off and I'm wondering, how do I get to everything? And I lead with an open-ended question, what is most important to you today? But now I really want to go back to my clinic and say, well, is this prioritized already? And then I can just jump into what they want and let them lead it. Separately, I'm curious as to what do we waste our time on? The last point in the slide here, what do we think that we need to spend time on that the patients don't find valuable? Was there specifics on that?
Help set priorities with people. Did you have a question?
Yeah, I was just going to make a comment that we've considered putting pre-selected options, right? Kind of like the topics that you have so that patients may not have to generate those thoughts themselves, but would be able to select from kind of a menu of options. And that's one of the things that we're considering as another test of change.
Thank you, everybody.
Wonderful job. I think these two presentations went together really nicely. So whoever organized this, terrific. All right. Our next speaker, so we have a really great diversity in terms of the care team. This is Adelina Bustamante Cohen. So got that right. And she's from NYU Langone, so right here in town. We're going to pull up her presentation. It is, I think, something that is really important for all of us, and that's on pre-visit diabetes device data capture. Anybody working on that in their clinics? Yeah. Thank you. Take it away.
Hi, good morning, everyone. You can call me Eddie or ED, and I work with Dr. Gold and Dr. Natter over here. and our pediatric group over there too. All right, so excited to talk to you about our pre-visit diabetes device data capture. Some background. I think we all know how the data capture is essential for effective and efficient patient care. Some of the benefits I'll quickly go over. Patients are more active in their treatment, leading to better outcomes, improved glycemia. It's timestamped, so we can see how their self-management behavior changes over time, how their glycemic control changes over time, if they're at home, at school, what time of day, what activities they're doing. Some objective measures of I mentioned that. The data from multiple devices like pumps, glucose meters, CGMs, they're integrated and can be viewed together, as well as it provides remote review by healthcare provider and targeted diabetes care and education. These are some of the limits and challenges of uploading the diabetes device data, but I won't go through it here. I'll go through it the next slide. So for our QI project, we identified a deficit in pre-visit diabetes device data capture. One of the reasons we identify this for our QI is we didn't have a policy in place. We didn't have a process in place. And some of the technologies, equipment issues that stood in the way, tech literacy, lack of computer or lack of smartphones or compatible smartphones, lack of the necessary USB cables. There's just no universal cable available in general for all the different devices across different brands. Data sharing has not already been set up, as well as inability to connect because of the outdated diabetes devices out there. For equity issues, access to technology or lack of, once again, cell phone issues, compatible cell phone issues, lack of computer, as well as outdated device brands. So place and process, limited staff, it's time consuming, and we didn't have a standardized process of documenting these devices in the patient's chart. For people staffing, providers may be unaware to document these devices that their patients are on, as well as where to document them in the chart. We didn't have a dedicated staff to do these upload, download from all these diabetes devices, as well as I think one of the important things about patients is patients not remembering their username and passwords, even if we wanted to pull the data during the visits. So we aimed to increase our diabetes device data capture before patient visits, and strategies to improve our pre-visit download uploads or our data were implemented. So I wanted to spend some time on our methods, and thank you to Dr. Natter for our illustration. And our patient care coordinator, I think she's actually called patient access coordinator, Ginza Zurita. So we thank her for collecting the 2-week glucose data prior to the patient's scheduled visits. It was collected from November 2022 to April 2023, about 24 weeks, almost 6 months. Every day she logged and she tallied the available number of downloads, uploads to capture prior to patient visits. And every day she logged and tallied downloads and uploads that were actually captured prior to visits. Patients were notified in 2 ways. We use Epic, so we send out Epic MyChart message, and there's a follow-up phone call. So for the Epic MyChart message, it was sent 5 days before the patient's visits. Instructions were laid out on how they can download their diabetes device data or run their report. And then instructions were also laid out to how to upload their data, how to upload these reports as an attachment on MyChart prior to their visits, if they're not already linked. So the follow-up phone call was placed 24 to 48 hours prior to the patient's visits if they haven't uploaded their data already. And a reminder was made to download, upload their diabetes device data, or to encourage them to link their device with us. So this is a picture of our 5-day Epic MyChart message. Also in red, we tell them you must show up 30 minutes prior to your visits if you haven't done, these upload downloads. It's not already in their Epic Media. And I forgot to mention also, our secretaries, our support staff will indicate in the schedule section of Epic in the appointment notes, what issues they ran into for diabetes device data collection. This is the day before call script. and literally she'd have to ask, do you check your sugars? What do you use? And there are some steps. If you're using a meter, if you're tech equipped, if you're not tech equipped, these are the processes. And then if you have CGMs or some of these other devices, it's pretty laid out, the process instructions. So our results at week 1 of intervention, this was basically our baseline data. We captured about 43%. Data capture improved to an average of 52% over the intervention period of 24 weeks. We had a peak of 65%. The image, the figure shows the average percent diabetes device data captured pre-visit over about 6 months. So in conclusion, we all know that having that report enables us to tailor our patient care, to tailor our education, because we can have these clinical decisions together with the patient. We can have these discussions to make these clinical decisions. We attribute the increase in data capture due to the multimodal reminders. We attribute them because patients over time got more familiar with the process of sharing their data with us pre-visit, as well as patients had already started to link or had already linked their diabetes devices with our practice. Some of the limits, as I mentioned, it's time consuming. This was done by one person, our patient care or patient access coordinator, to collect the data, to call, to remind them, to instruct them, etc. There was a lot of hand holding. It's the timing of our data collection occurred over major holidays, so maybe it was affected by the difference in patient volume also, and type of diabetes device. So interestingly, though not collected, she said that glucose meters were harder to obtain prior to visits, perhaps because of the challenge in having the USB cable, and there's no cloud device, cloud capability compared to some of the CGMs, pumps, smart insulin pens that we have out there. For future steps, we continue to monitor and adjust our data capture strategies. For staffing consideration, we're happy to announce that we have a dedicated support staff whose primary function is to do this, to do the download, upload, send the reminders. And interventions to diabetes care after implementation, we continue to remind our clinicians to please write in your sticky note, in the sticky notes section of Epic, in the storyboard part, to indicate what diabetes device your patients are on. And also for patients to auto share their data at the initiation of CGMs or insulin pumps, whatever they're starting. These are my references. And thank you once again to our PCC, Ginzarita, Dr. Golden, Dr. Natter.
Great job. Questions from the group? I've got one in the back. Stay up here, I'll be back. This is good. My watch is fully charged, so I'm counting every step.
Edie, awesome presentation. That's a huge challenge that we are all grappling with wherever we are. Andrew Lovick, Cleveland Clinic Children's. Previously, I was at Cincinnati Children's, and we did a QI project related to upload prior to clinic there. So I've been in the space too, from a QI standpoint too. And I love that comment about how you put into your paper that 30 minutes, come 30 minutes beforehand if you haven't uploaded. One thing we struggled with is how do we sort of offhand that and explain that this is sort of a change the script that we were doing all of our uploads in clinic. And so trying to flip the script and say, can you do this beforehand? And then feeling like how our family is going to respond to that. And I think that kind of placing it as an option that they could come early or upload ahead of time was a great way to do it. And then a couple of comments, two things we found that were really helpful were, this is in children, but having the all new device startups, just making sure we had them linked in and sharing and making that our standard. So we had it going forwards. And then the other piece, let's see, what was it? I'll reach back out to you after. I can't remember what I wanted to say, but awesome job.
I've got more questions right here at this table. Hang on.
Hi, Ryan McDonough, Children's Mercy, Kansas City. So one of the biggest hurdles we've been dealing with most recently is those Omnipod 5 people who are self-starters and are not getting connected to Gluco. And then we see is that I just by the giggles in the room, I hear that that's obviously a well-known issue, but have you appreciated any device specific improvements, or has this just been really global?
Yeah, so we have another QI coming up down the work. So it's specifically about the insulin pump. So I'm working closely with our support staff, again, our RNs, our endocrinologists. That was one of our challenges, to capture those self-starters for Omnipod, for upgrades also. For Tandem, they're not readily available. We're working closely with our pump reps to get those names for that endpoint. That's to make sure that they have their 2 to 3 week post-pump training or upgrade follow-up. But I also wanted to share some really quick data, not reported. So I came on board after this intervention was done. I joined in March, so I guess they were just wrapping up the data collection. So I helped put it together, lots of talking and asking, like, why did this happen, et cetera. So we did a post-implementation checkup on how our process is going. And I think in general, what makes this process work is we collect the data collection that we were able to obtain the reports, these data at the day of their visits about 90% of the time. So we ran into some issues because of some outdated devices, or just patients forgot their stuff. So I thought that was interesting, but there's, the data collection for that post implementation was a little bit different, because I collected the data retrospectively, and then also we had a new staff member who was doing all these calls and stuff rather than our PCC.
We'll take one more in the back, and then we're going to move on. Yep. Yeah, please just shout it out.
Streamlining the process. We were just chatting about how a lot of them are building into the app automatic data upload, but then that's the battery stuff. So how do we balance? Because the kids are just going to close out the apps. So I don't know if anyone's speaking to the device companies to make sure that this is something that they can also think about.
Yeah, I can speak just briefly about it. I guess more we're speaking to IT at our institution, and they're speaking to the companies, but we did spend a lot of time over the past few years talking to Gluco, which then fell off when, for a variety of reasons, the cost became exponentially problematic. So we thought we were close actually to having at least a semi-universal sort of portal. We've obviously moved away from that. We've reinitiated now. We're talking to Tidepool, and we're doing it in conjunction with Pediatrics and with all of our network hospitals, trying to leverage that. I think at the last meeting of this group, we talked about trying to leverage this group to do that all together, because the costs are so prohibitive. And if we could do it once and then apply it in most places, it would be great. We also have a pretty large Hasidic population, and there's other folks who may not have access to technology, but we actually have to just remember that there's going to be a substantial group of people not doing this. And I like to remind my younger colleagues, because I'm old, that paper still works. And that group, for example, will bring in paper logs, they will fax, but they will not use the internet unless required. So I'm just reminding everybody, data is data. If they want to do the homework to bring it and write it down, fine with me. So we can usually get something. And when we don't have access to a download, the MAs actually bring the patient a piece of paper and a little chart and have them sit there while they're waiting for us to come in. They write down something, we congratulate them, and we do the best with that we can. But I do think it's a bigger sort of network problem. I don't know, if you could speak to that.
When we do talk with device companies, we do say that everything has to be on the cloud. We just, it has to be. So, if you have the connection, and, for our registry, we have patients or people with diabetes giving us clarity data through Dexcom, but it's just doing it manually every time doesn't work. So you have to set it up so that it's auto feeding on the cloud.
And then auto feeding into your EMR.
Auto feeding into the EMR. Yes. Yes. I think we're hearing again, as we heard, one of the themes yesterday was that collectively, this is a very powerful voice and maybe some advocacy is in order. So thank you for raising the point and for your solutions. Does anybody in the room want Edie's templates, or would they like to get their hands on them? I saw some photos. So this is your chance to make that connection. And can what we learned in this presentation solve the question in the last presentation? Meaning, have you found in your clinical practice that having those data in advance limits the time you spend with your back to the family doing something in the EHR? Is that happening in your clinical practices? Yeah, great. All right, let's bring our next speaker up. You don't want to hear from me. You want to hear from them. They've done all the work. All right, this is Dr. Grace Nelson. She's going to be talking about incorporating shared decision-making. Let me move you forward. Yep. Using a shared decision-making model to increase pump use.
All right. And so this is a little bit of a change, I think, from our last couple presentations, just a bit, although maybe at least linking back to the first couple. So this is where we started. This is our baseline data. I'm from Le Bonheur Children's. Sorry, that was up there. We're in Memphis, Tennessee. We have a pretty large Black population, almost 50% of our clinic. It's an interesting part of the country. And so for a variety of reasons, our baseline data from November of 2020 through April 2021, this is our baseline data of pump use in the clinic. It's low, 20%. That orange line is of patients on a pump, what percentage were white, and then the blue lines of patients on pump, what percentage are Black. So you can see very inequitable and very low. This was our insulin pump process. It's a busy slide on purpose. I'm not going to focus on all of it today, but there's a lot of pieces that could have been made better. Where I'm going to start is that the beginning of the process, so provider and patients decide to initiate the pump process, right? That's kind of a vague statement. So how did that, how do we get that happening more? What does that mean? And then the next step, which was there was a set of stringent guidelines that really, it wasn't just a provider decision, although that was maybe the first part, but it was also this sort of general clinic decision, this committee that would decide if patients could be on a pump. So we've been working on this project for a long time. I'm not going to talk about all the stuff today. This pump committee, I will say, it was put into place many years before to avoid the misuse of pumps. And this was before CGMs were widely available and definitely before hybrid closed loop. And the clinic decided they didn't like having to pull patients off a pump when they kept going into DKA. So they wanted to make a pump committee to avoid this. It worked really well. Like, we stopped pulling patients off pump because it turns out if you don't put anyone on a pump, you can't pull them off the pump. So it did what it was supposed to. The criteria, though, the biggest thing was A1C less than 9, ideally less than 8. You'd have to fight kind of hard if it was between 8 and 9. Evidence of regular premeal bolusing, good attendance to classes and all your appointments, no hospital admissions since new onset, and no social concerns, no concerns about chaos in the house, which is obviously, potentially coded language, right? And so we decided that this was outdated and we had to make a change, but there was a whole mentality in our clinic that was going to be unsafe. We were going to cause problems. So we got together with all these committee people and we said, please let us do this with like 10 patients. We'll watch them really close. We'll call them all the time. We'll follow them. We'll be so careful. Please let us do it. So they're like, okay. So we said, you have to have an A1C over 9. You do need to attend clinic visits, right? We had to have the patients coming in order to do this. We did originally say no DKA for the last 6 months. And then the most important thing, you'd be wearing your CGM, right? Because you can't make a hybrid closed loop work without a CGM. So that was it. A1C over 9, wearing a CGM. Initially, these were our rules. They kind of got lax as we went on. You can see the A1C initially was pretty high and it dropped. I still love commenting that the A1C after 1 to 2 weeks on the pump dropped. And I attribute that to patients' hope of realizing they're not going to just be on MDI. So being able to make some changes, knowing that they're soon going to have a pump. So I thought that was cool, but it worked. So then we wanted to roll it out to more patients. And I thought we were just going to have patients like knocking on our doors, like, yes, I'm ready to start a pump, put me on it. But it turned out we weren't asking enough people about it or talking about it in clinic enough. And especially our patients with higher A1Cs, we were troubleshooting in the moment and not necessarily jumping to the pump regularly enough. So we started with 2 different handouts. The first one was the My Diabetes Journey that we took from UAB, and just asking about their diabetes. And then, but there's lots of questions about technology on here. And that was a cool start. Definitely had patients talking, ones that were on technology, talking about how they liked it, and some people saying they were interested in learning more. But then I realized that some people didn't even really know where to start with all these technology words. So we added a handout just very briefly saying, this is technology. Here's, if you want to learn more, then you can ask. And that really helped give patients a baseline of like, when we're saying technology, when we're saying smart pen, when we're saying CGM, this is kind of what we mean. And you can ask more. And personally, I had a number of patients who, I won't lie, I was like, this, I can't go down technology right now. This has been an overwhelming visit, like hand on the door. And they go, hey, I'm interested in a pump or a CGM. And it's like, oh my gosh, okay, let's do this. So the survey results that we did this for about 4 months, and 72% of the patients were not using a pump, which was pretty consistent with our pump use at the time. And 51% of those were interested in a pump. And 30% of those got a pump within the next 3 months. There was more that then had to get a CGM and then a pump. So hopefully that number is higher now. If we went back and looked, I think it would be. And then I just love this word cloud. I had to put out some brand names that patients put. So excuse the sort of weirdness of it, but just use your imagination. It's really cool because it's fun to see that patients really do say that technology helps them. Like that was that and mom, one of the most helpful things. So this is our pump use run chart. So we started our heartbreak closed loop group and then removed our A1C criteria in the clinic. So that pump committee disappeared. We started to get there's new pump options available, like the Omnipod 5 and stuff became available later on, and then more insurance availability. And we've improved. We've gone from an average of just over 20% to 40% pump use. And our Black patients have gone from 10% of our pump users to 20%. My attempt to look a little closer at how we're doing with our equity, the closer we got, this should be as close to 100 as we can get. We're not there yet, but we're making small improvements and we're working on it. So we are changing our overall process. The next steps is changing our overall process to introduce pumps sooner, and then changing our post-pump education to work on those common pitfalls. And then our next big project that we're going to take with the new year is really targeting all our patients with A1Cs over 9.5 and working on explaining to them and teaching them and showing them how the pump can be helpful so that they know that that would be helpful for them and we can get them on it. And those are my references. Thank you.
Terrific presentation. Great job. Questions from the group? So I have one for you. How did the team work on this project? It sounds like you led it, but how did you engage the rest of the team?
Well, and especially initially, it was, Blake, my QI coordinator, did a lot of phone calls. There was a lot of phone calls to families, following up, getting them on the pumps, following them after. But also we were constantly talking with our educators, all the clinic people to help keep them abreast of what was going on and make them comfortable with trying this newfangled thing in people that were previously considered high risk. And so it really became a whole clinic process. And then it expanded out, and naturally the idea of an A1C limit just fell to the wayside. And we're like fully done with the pump committee, and it didn't necessarily come from us saying it needed to happen. It like came from internally in the clinic, which was really cool. Yes.
Not just the doctors, but the nurses who created like binders that let the nurses so they could easily flip through, so they could have conversations with patients.
Yeah, we provided much better of the triaging notebook that the nurses answer a lot of those blood sugar calls, and we gave them better information to help with troubleshooting of the pump and education.
Yeah, I love that notion of changing not just a process, but a culture, because that's probably the more sustainable change. So thanks for sort of verbalizing that. Or
great work. I think that's wonderful. We are also embarking on this, and part of our philosophy has been the clinic cannot be a barrier to pumps. So we're working on removing that. We have a large population of language other than English. How are you addressing that?
Not super well right now. It's not great. That's probably another thing that we need to start working on. We have a couple patients, but like I can think of a handful of like our Spanish speaking patients that we've had to like kind of go above and beyond to get that information for them. And that's probably a next step we got to work on.
I just think it's worth a moment to say thank you for what you're doing. I think medicine is kind of, stuck in very archaic, hierarchical, and sometimes unfortunately racist ways. And I think it's important that we take a moment to thank you for trying to change that. So I think that's great. Yeah.
Well, and I think that's all of us, right? So thank you guys.
Thank you. I agree. Thank you for the work you're doing. I have two questions. Well, first of all, I have a comment. The concept of earning a pump is just a really strange concept to me, and earning things that can help one's health in general is just a whole nother conversation. But my other question is, besides the pump committee, did you identify other barriers why patients don't want to go on pumps, especially the Black population?
No, and that's something that we're starting to work on. I think I asked questions about this with Amy and Jeff yesterday too. And I think our next thing is going to be really taking our patients that have been on pumps and trying to engage them with our people that aren't on pumps, and trying to get patients to see, I mean, I have a pump, like half our clinic has diabetes and is on some kind of pump, and that we're walking around, but we are providers and we're adults. And so I think we need to show patients, other patients, and get them to see it, because that's the next step, and it's tough.
Yeah, I'll say I came from the Naomi Berry Diabetes Center before my life here, and that was a very education-based system with a lot of patient classes. And one of the best classes there was and Janice will probably remember this, like, you're thinking of going on a pump. And so the educators would run that, and there could be 5 or 10 or 15 or 20 people. They were adults, they were kids. It was like just a slice of life, kind of like the waiting room there. And a lot of those folks ended up going on pumps kind of around the same time and staying in touch. And certainly some of my patients did. And then in the waiting room, I'd see like the mother of a pediatric 5-year-old talking to my young adult in college, and the kids just sitting out there like showing off the technology. And then I'd get like my 50 or 60-year-old recalcitrant, I'm like absolutely never going on a pump, come to me and say, well, I just saw the mother with that 5-year-old out there, and if that kid can do it, I can do it. So I think if you can get people in a room together, it doesn't really, age doesn't necessarily matter, but if you can find some way to do it, it's more successful probably than anything that we said in the patient room. So.
Let's give Dr. Nelson another hand for that presentation. Terrific work. And if you're not as persuasive as Dr. Nelson, just a reminder that the ISPAD guidelines in 2022 state very explicitly that children and families should not be required to earn technology. And if you have institutional barriers, and again, you can't get around them, maybe you can take that guideline to the pump committee or other such entity to make your case. We are moving on to our final speaker. So very exciting. Come on up. So this is Dr. Guido Alacron. Excellent. Right. And he's going to be talking about improving self-management habits with remote patient monitoring and a very cool program called Rocket. Great acronym.
Well, everything has to be related with space in Houston. So thank you. I'm Guido. I'm a 3rd-year pediatric endocrinology fellow at Texas Children's Hospital, and I have the honor to present at least the initial results of this program. And most of the things big part of this project is around the 6 diabetes self-management habits that many of you might be familiar with. But back in 2021, Joyce Lee and her group at the University of Michigan look at the association of performing certain habits with having better glycemic outcomes. And they basically group them in these three large groups, which are effective glucose monitoring, where it comes the first habit, that is checking blood glucoses more than 3 times daily or wearing a CGM. The second large group was around effective insulin delivery, which have 3 other habits that are giving at least 3 boluses per day, wearing insulin pump, or giving boluses before meal. And lastly, the third large group is effective use of diabetes data, that has the 2 last habits that are around downloaded device data and adjusting insulin doses in between visits with providers. And what they found is that performing each of these habits is associated with a lower A1C. So this was incorporated into the Rocket T1D program, but what is this program about? This is a remote patient monitoring program that aims to enhance the diabetes management for youth with T1D and their families. And our goals are to improve technology knowledge, increase the effective use of glucose monitoring, optimize the insulin delivery, but ultimately what matters is the having better glycemic control in our patients. So the target population that we are currently focusing on are the new onset patients with type 1 diabetes, but also we take some of those that are established patients, especially those who are interested on starting technologies or are having thoughts about getting into the diabetes technologies. So the program is divided in 2 phases. The first the initial phase we have labeled as the launch phase, and it consists on weekly virtual visits or telephone calls with CDCSs or a provider. And the discussion topics are focused mainly on the diabetes habits, but also if they are interested in other topics related to diabetes, that's also part of the discussion. And then the subsequent phase it's called the orbit phase, where the point of contact with the families are more spaced out, and it consists on monthly remote monitoring of the cloud connected devices. We look at their data, and if there are any therapies adjustments that need to be done, we tell the patients. So we are fortunate enough to have a big team to be part of this group. We have 2 diabetes educators that are focusing mainly on the new onset patients, but also we have 3 others that are helping us with the established patients and also the orbit phases, the orbit phase. And we have the other ancillary support here. The platform that we offer, mainly they are phone calls, and we have created a Rocket T1D line so the patients know when we are calling them. But also we offer a video platform if that's desired by the family. And the communication with the families in between these encounters are mainly through my chart or text messages. And as I was saying before, the points of discussions are obviously around the diabetes habits, but it's also important to incorporate certain educational aspects that are important for families to know or perhaps to review, like sick day management, troubleshooting the devices. And in the first visit, actually, we always ask if they have any other diabetes related goals that they want to discuss. And to support this education, we have created also a educational binder that we have labeled as the flight manual. And this has been an amazing collaboration with the University of Michigan. So thank you so much, guys. So the purpose of creating this educational binder is to have was to have a short, concise, and user-friendly educational material that obviously is around or incorporates the habits, but also important aspects of diabetes. So this is the table of content, the 6 habits, and perhaps sick days management and other things. And I perhaps just want to show you some of the material that we have inside. Most of these resources were pre-existing material, but we modified that to be to meet the goals of the program. So with all this, coming to the aim of this part of the project, which is increasing the use of the 6 diabetes self-management habits by at least 2 habits from enrollment to completion of the launch phase in more than 80% of youth with T1D enrolled in the Rocket T1D program. So for example, if a patient is performing 1 habit at enrollment, the goal is to get to 3 or more than that. So here are some of the initial results. We have graduated as of now 52 patients, but we have enrolled more than 100 right now. And this bar chart is showing the absolute numbers of the performance of each of the habits before enrollment, as you can see with the aquamarine bars. And then following the intervention, for the most part, they went up by a lot, showed as the purple bars. And you can see perhaps with these graphics in the left upper corner, in order of frequency of the habit performance from left to right, the habits that were less performed were perhaps habit 3, 5, and 6. But then in the right lower corner, this Pareto chart is showing the results after the intervention, and most of them went up. Perhaps the one that we need to keep working is the habit 3, which is where insulin pump. And this last bar chart is just to show the cumulative improvement of habits in all the patients and kind of to link it to the aim. And as a reminder, the aim was to increase the performance of at least 2 habits from enrollment to graduation. And fortunately enough, more than 80% of these patients have improved by more than 2 habits. So in conclusions, 88% of patients had an increase of at least 2 diabetes self-management habits from enrollment to completion. The most pronounced effect has been seen in the effective use of diabetes data. And I think it's significant enough to mention that there was a more than 50% increase in insulin pump use. What is next? We are looking also at the glycemic metrics before and after graduation. But that's more to come. And we are envisioning also on having a Spanish version of the flight manual. And lastly, I just want to thank everyone who has been part of this group, including the co-authors. I see some here. Dawn, Ashley, thank you, and Dr. Lyons.
Terrific. That's great. That was the 5th of 5 really terrific presentations. Questions from the group? Yes.
Thank you. That was a great presentation. I have some questions about, I think it's habit number 6 and insulin dose adjustments between encounters. What does that mean? Self-insulin dose adjustments. I heard you say something about with providers. So does it mean getting input from the clinical team or learning how to do it oneself?
Yeah, so kind of the purpose of including this habit is based on the fact that, we spend with the patients just probably a total of 2 hours a year because we have only 4 visits with them. And then in between those visits, they face different things, and perhaps getting them the empowerment of looking at their data and adjusting the doses on their own could improve actually their glycemic control. So the purpose of this program is teaching them how to look into their data and doing adjustments in between visits. And perhaps Ashley wants to.
You all hear her. The way that we define habit 6 about dose adjustments is we will mark it as a yes if the patient had any dose changes between visits. So whether it was initiated by our team or it was self-initiated, we still count it as they adjusted a dose because they still made a change to their regimen. We have a class that we teach families how to make dose adjustments themselves, but we always give the disclaimer that, if you're not feeling confident or you're not sure, you can always contact our team. But it's really an extension of the retrospective data review that once we start to socialize looking at your data and seeing where there's patterns, even if they don't feel comfortable knowing exactly what changes to make. They're saying, oh, my kid is really high after lunch and I feel like I need to do this, or I'm not sure what I need to do. But it's like they're taking an action versus just waiting, like said, until the next time we see them, which has a lot of opportunity to optimize time and range and all of that in between visits.